Received from Deputy Roisin Shortall and Senator Annie Hoey. Good morning, everyone. One piece of housekeeping before I bring the witnesses. Draft minutes for meetings of 6th, 7th, 12th, 13th, 14th and 15th July. Can I take it that the draft minutes of our public joint committee meetings of 6th, 7th, 12th, 15th of July and also the private meeting on the 13th and 14th of July 2021, the public session on the 13th and 14th of July 2021 are agreed? Is that agreed? That's just the formal stuff. Thank you. I'd now like to welcome our witnesses from the HSE, the Department of Health and the Health Products Regulatory Authority to our meeting this morning, who will be providing us with an update on the Medical Cannabis Access Program. I welcome from the HSE Mr Shaun Flannagan, Assistant National Director, HSE Primary Care Reimbursement Service, PCRCS, and Professor Brian Lynch, Consultant Paediatric Neurologist, Children's University Hospital, Temple Street. From the Department of Health, Mr Muiris O Connor, Assistant Secretary, Research and Development and Health Analytics Division. Ms Anne-Marie Seymour, Principal Officer, Medicines Control, Drugs and Pharmacy Legislation Unit. Mr Conor Brennan, Assistant Principal Officer, Medicines Control, Drugs and Pharmacy Legislation Unit. And finally, from the Health Products Regulatory Authority, I welcome Ms Loraine Nolan, Chief Executive, Ms Grania Power, Director of Human Products, Authorisation and Registration, and Ms Aoife Farrell, Health Products Distribution Manager. Members, you're all very welcome. Members now have the option of being physically present in the committee room or may join the meeting remotely from Leinster House. Members and all in attendance are asked to exercise personal responsibility in protecting themselves and others from risk of contacting COVID-19. You're strongly advised to practice good hand hygiene and leave at least one vacant seat between you and others attending. You should also maintain an appropriate level of social distance during and after the meetings. Masks, preferably of medical grade, should be worn at all times during the meeting, except when speaking, and I ask for your full cooperation in this. But before we have the opening statements, again, this is the formal thing, I need to point out to our witnesses that there is uncertainty if parliamentary privilege will apply to your evidence from a location outside of the parliamentary precincts of Leinster House. Therefore, if you're directed by me to cease giving evidence in relation to a particular matter, you must respect that direction. So can I call on Muiris O Connor from the Department of Health to make your opening remarks. You're very welcome, Muiris.
Good morning. Good morning, Chair and members of the Joint Health Committee. Can I just check that you can hear me okay?
Loud and clear.
Super, super. Thank you, Chair and Deputies, for the opportunity to address the Committee on the Medical Cannabis Access Program this morning. To put cannabis in context, it is a Schedule 1 controlled drug under the Misuse of Drugs Act and is therefore subject to strict levels of control. And access is allowed under licence for limited purposes only. As the name would indicate, the purpose of the MCAP is to enable access to a controlled substance which otherwise would not be legally available to patients. In this case, the controlled substance is tetrahydrocannabinol, known as THC, a psychoactive derivative of cannabis. Cannabidiol, known as CBD, another extract of cannabis, is not of itself a controlled substance, and the MCAP is not intended as a means of accessing CBD-based products. The Ministerial Licence Programme, in operation since 2017, is similar in that it enables, with the support of a consultant, a GP, to prescribe cannabis-based products where the patient is regularly monitored by a consultant. You will be aware that in recent years, in both Ireland and abroad, the subject of using cannabis products for medical reasons has become an issue of social and political debate, with calls for cannabis products to be made available to Irish patients. Owing to this increasing interest, in December 2016, the Minister for Health requested the Health Products Regulatory Authority to provide scientific advice on the use of cannabis for medical purposes. Our colleagues in the HPRA will be able to elucidate further their findings in this review. Following publication of this HPRA report, the Minister for Health established an expert reference group to provide clinical guidelines for the development of a medical cannabis access program. Acknowledging that some time has passed since the last review of the clinical evidence supporting the use of cannabis for medical reasons was done, the department is currently working to commence a new clinical review that will continue the work of the previous clinical expert group. And this review will seek to build on evidence found in the earlier study and will assess if there is new information to support the addition of any other clinical indications to the MCAP. Following the recommendations of the HPRA review in 2017, and importantly the subsequent clinical guidance, the department commenced work on the development of legislative basis for an access programme. This was done in consultation with HPRA and representatives from the expert reference group, and in June 2019 the legislation was enacted. Statutory Instrument 262/2109, the Misuse of Drugs, Prescription and Control of Supply of Cannabis for Medical Use, Regulations 2019, sets out the legal provisions for the operation of the Medical Cannabis Access Program and the legal obligations for healthcare professionals and commercial obligations under the programme. It also sets out how the access programme will work, who can avail of it, how it will be operated by the HSE, and how cannabis-based products made from whole dried flowers of the plant are accepted for use under the programme and placed on Schedule 1 of the Regulations SI. It is a pilot programme for 5 years and may be extended for a further period. My colleagues from the HPRA can assist the committee with questions on the process leading to the inclusion of a product on the schedule for use under the MCAP. It is the Minister for Health who ultimately decides if a product goes on the schedule. However, it is the sole responsibility of the supplier to apply to be considered for inclusion on the MCAP. There are currently 4 cannabis products on the schedule and 2 more are to be added to Schedule 1 of the regulations in the coming weeks. I understand that one of the products on the schedule, namely Canapil, is expected to be available in October. Subsequent to the introduction of the necessary legislation, the department has been working with the HSE, who will, pursuant to the requirements of the SI, operate the register of consultants and patients who will access the programme. This engagement culminated in the MCAP being made part of the HSE delivery plan for 2021. In July, it was announced that the HSE was ready to accept registrations of clinicians and their patients as required under the regulations, and our colleagues from HSE will be able to advise on how the MCAP will operate in practice. On the ministerial licence programme, to meet the clinical demand for medical cannabis prior to the establishment of the MCAP, the Minister for Health initiated in 2017 a programme whereby licences granted under Section 14 of the Misuse of Drugs Act can be issued to practitioners on behalf of patients where the clinician could prescribe, import, possess, supply and administer the controlled substance listed in the licence. A detailed application is required from the clinician describing the indication the patient has, the fact that all other meds have been exhausted or are no longer adding value to the quality of life of the patient, and advising that they are prepared to prescribe cannabis oils and monitor their patient while using such products. Such applications must also comply with recommendations made by the Chief Medical Officer, who advised that the granting of an individual licence under the Misuse of Drugs Act for the use of cannabis for medical purposes by the Minister for Health sets aside the usual regulatory processes which are in place to protect the public and which ensure that only those medications which have been found to be both effective and safe are made available to the public. Therefore, it is crucial that the granting of any such licence takes due care and consideration of the potential unintended consequences associated with the prescription of cannabis, a Schedule 1 controlled drug for medical purposes, and that its use is endorsed by a consultant who is familiar with and responsible for the care of the individual for whom the licence application is being made. The CMO also noted that the independence of the doctor-patient relationship is a fundamental principle upon which medical practice is based, and that it would be neither appropriate nor ethical for the Minister for Health to seek to influence this relationship. Currently, there's 192 licences have been issued in respect of 67 patients. The products prescribed are all sourced from a pharmacy in The Hague, in the Netherlands, called Transvaal Apotheek. The products are compounded by the pharmacy itself. Transvaal is a well-established GMP facility and is a reliable supply chain for clinicians and their patients. The Netherlands authorities, however, do not allow the export of cannabis oils from the Netherlands to wholesalers or pharmacies, but they do allow individual prescriptions to be dispensed. And owing to the Dutch authorities' restrictions in this regard, it is not open to the manufacturers of those cannabis products to apply to the HPRA to have their products included on Schedule 1 of the regulations. So, with that in mind, representations were made by the Minister for Health to the Dutch authorities to request that the products could be commercially imported for inclusion on the MCAP. However, Dutch authorities stated that magistral preparations may only be provided directly to patients or their representatives on the basis of a prescription. Notwithstanding this, the patients who are currently being treated with these products can continue to access them under the ministerial licence issued to their clinicians. And due to COVID-related travel restrictions, in May 2020, the Department of Health put in place a courier system to facilitate the collection of products from the Netherlands for delivery directly to patients' homes. A decision has been made to retain this method of supply for patients accessing cannabis-based products in this way. Additionally, in July of this year, a direct funding scheme for eligible patients was commenced between the HSE and the dispensing pharmacy in the Netherlands. And the pharmacy now directly invoices the HSE, and this removes the need for eligible patients or their families to pay for the products up front and then subsequently seek reimbursement. I hope that the above has given you an overview of the MCAP and the ministerial licence arrangements. Colleagues from HSE will speak on the operation of the MCAP and any reimbursement questions you may have, and HPRA colleagues will discuss how products get accepted for entry onto the MCAP. Thank you, Chair.
Thank you, Muiris. I now call on Shaun Flannagan from the HSE to make your opening remarks.
Just check, can you hear me okay?
Yes, Sean, walk away.
Okay, grand. Okay, thank you, Chairman and members, for the invitation today to meet with the committee to discuss the Medicinal Cannabis Access Program. I'm joined by my colleague, I'm joined by Professor Brian Lynch, who's a consultant paediatric neurologist based in the Children's University Hospital in Temple Street, and Professor Lynch will have a clinical perspective on the issues to be discussed. As background, you'll all be aware that the Primary Care Reimbursement Service is responsible for ensuring that eligibility is in place for qualifying persons for most of the primary care schemes and other arrangements within the health service, and PCRS is also generally responsible for making payments of the order of €3.269 billion to primary care healthcare practitioners and HSE acute hospitals. As Muiris has stated, under the HSE National Service Plan in 2021, PCRS was given the responsibility on behalf of the HSE to manage the Medicinal Cannabis Access Program, subject to the availability of suitable products, and as part of that, to establish arrangements to approve their use in relevant cases and record relevant information on the register as provided for in the legislation. PCRS also has the responsibility to consider, pursuant to the requirements of the Health Pricing and Supply of Medical Goods Act 2013, applications for pricing and requests for reimbursement of MCAP products for individual patients. There are currently three specified therapeutic indications or uses set out in the schedule of the Misuse of Drugs Regulations 2019. I won't go through them because I know the committee is aware of them. In relation to the operation of the register, a practitioner who has to be a medical consultant can only issue a prescription for an MCAP product where an individual's name has been entered into the register and what is called a Cannabis for Medical Use Register Number, or a CMUR number for short, will have been provided by the HSE in relation to that individual. So therefore, medical consultants are required to provide the HSE with the following information before they issue a first prescription. They provide the name, address, date of birth, the specified therapeutic indication, i.e. which of the three currently approved uses under the MedCap that the person is going to be treated for, the name, the registration number, the medical speciality of the notifying consultant, and such additional information as the HSE may require. And then a person supplying a specified controlled drug, such as a pharmacist or a pharmacy, is required to provide his/her name and address to the HSE, the name and address of the person who supplied them, and the following details from the prescription: the date on which supply was made, the name, the quantity, where appropriate, the dosage form and strength of the product, the dose supplied, the name, address and registration number of the consultant prescriber, the CMUR number, name and address of the person who received the prescription, and the date of the prescription. And then but in the legislation, there is a requirement to provide any further information required by the HSE. The HSE is then required to record all of the above information in the MCAP register and to assign CMUR numbers as required. The HSE is required to preserve all the information in the register for at least 5 years from receipt. Turning to supply, Schedule 1 of the Misuse of Drugs Prescription Controlled Supply of Cannabis for Medical Use Regulations 2019, as amended, sets out the products which can, subject to availability, be supplied under the MCAP. There are currently, as Muiris stated, 4 products listed in Schedule 1. The HSE does not decide which products are included in Schedule 1. That's a ministerial function. At this point, the suppliers of 2 products, those of a product called Cathal and a product called Tilray Oral Solution, have submitted final pricing positions to the HSE. and the HSE confirmed acceptance of those prices in writing to the suppliers in June 2021. The HSE currently expects that one product, i.e. Cannapil, will become available during October 2021. The suppliers of the second product, Tilray Oral Solution, have indicated their intention to supply the Irish market, but to date have not confirmed when product will be available. The HSE understands that the supplier of the other two products does not currently have plans to supply the Irish market. I now turn to reimbursement. In making general decisions on reimbursement, the HSE is required under the Health Pricing and Supply of Medical Goods Act 2013 to consider 9 criteria set out in that legislation. The HSE is required to consider the health needs of the public, cost effectiveness, the availability and supply of items for supply and reimbursement, the proposed costs, benefits and risks of an item relative to therapeutically similar items, and the level of certainty in relation to those costs, benefits and risks, the budget impact, the clinical need for the item, the appropriate level of clinical supervision required to ensure patient safety, efficacy, which means performance in clinical trials, effectiveness, which means performance in real situations, and added therapeutic against existing standards of treatment. And then finally, the HSE is required to consider the resources that are available to the HSE. In terms of reimbursement, the department has previously advised the HSE that it considers that Section 23 of the Health Act 2013 appeared to be the most suitable legislative option for reimbursement on a managed access basis of community supply of MCAP products. And Section 23 of the Health Act allows the HSE discretion, subject to conditions as it considers appropriate, to make arrangements to supply an item to a patient, notwithstanding that the item isn't normally reimbursed, provided the HSE is satisfied that the patient requires the item for clinical reasons and provided there is no reimbursed item which is a suitable alternative for that patient. The intent of the HSE is therefore obviously to utilise Section 23 to enable reimbursement of MCAP products where appropriate. In practical terms, how does this work? How will this work? The HSE has designed an application form for prescribers to register a person to be treated. The application form will include all of the information required to register an individual on the MCAP. The HSE will then assign a CMUR number and will also provide the applicant prescriber with a specific pro forma prescription form for the MCAP, which will contain all the information legally required, including the relevant CMUR number for the operation of the MCAP. I'm available. Obviously, we will answer any questions that the committee has. And that concludes my opening statement. Thank you.
Thanks very much, Sean. And finally, can I call on Loraine Nolan from HPRA to make your opening remarks?
Can I just check that you can hear me first of all?
I can. Thanks very much. Loraine, go ahead.
Great. Good morning, Chair and members of the Joint Health Committee. We welcome the opportunity to come before you again to provide the committee with information on the Medical Cannabis Access Program, or MCAP, the HPRA's role in this, and to answer any questions that you may have on the programme. In setting the context for our discussion today, it is important to be clear on the status of the products that may be considered under this access programme, what they are, and importantly, what they are not. In doing so, it may be helpful to return to some key aspects of the HPRA's 2017 review. That review considered the scientific data available at the time in relation to medical use of cannabis, which was extremely limited and fell well short of the standard required for medicine to receive market access. The review concluded that from a policy perspective, should the Minister consider it in societal interest to establish a cannabis access programme, that should be in a limited set of circumstances for 3 specified medical conditions where it can be considered, and the committee will be familiar with these. A key recommendation for the programme was that it would need to take into account that access should only be provided where patients with the specified conditions have a clear unmet clinical need, meaning that they have failed to respond to treatment with all available authorised medicines. These limited recommendations were also based on the fact that the safety and efficacy data available did not support a wider form of access. The report also advised that cannabis-based products that may be available or through such a programme should not be confused with authorised medicines and are not equivalent to them. Authorised medicines undergo comprehensive clinical and quality evaluation, including clinical trials, to assess their safety and their efficacy. The data generated from these studies is reviewed by scientists and companies to determine if there is a positive benefit-risk ratio, and if so, this data is submitted as part of an application for marketing authorisation. This application is then reviewed by medicines regulators, such as the HPRA, to establish if they agree with the conclusion of benefit-risk assessment, and where this is the case, the medicine is authorised. not meaning to detract from the focus on cannabis, but something perhaps the pandemic has shown in a very real way is how this process for authorisation of medicines works in practice. It also has increased the public understanding, appreciation and value of this process. As the committee are aware, there are 2 cannabis-based products that are authorised as medicines. These are Sativex oral mucosal spray for the treatment of spasticity in multiple sclerosis, and Epidiolex oral solution for the treatment of seizures associated with Lennox-Gastaut syndrome, Dravet syndrome, or tuberous sclerosis complex. Both products have met the standards and level of data required to receive a marketing authorisation. As such, these are quite distinct and do not fall under the scope of MCAP. Provision for the MCAP was made under regulations developed by the Department of Health in 2019. These set out how the programme operates in terms of prescribing, supply to patient, and subsequent patient monitoring. They also define the criteria a cannabis-based product must meet in order to be considered for inclusion. The regulations are importantly supported by clinical guidance that was generated by an expert reference group convened by the Department of Health in 2017. This publicly available guidance underpins the introduction of the Access Programme. It also highlights a very important point around the decision to enrol a patient in the MCAP, and that is the relationship between the patient and the doctor is paramount in terms of clinical oversight. That clinical oversight allows for consideration of critical issues such as disease progression, whether all conventional treatment options with authorised medicines have been exhausted, and the doctor's decision as to whether these products may then be a suitable option for their patient. The role of the HPRA in MCAP is quite distinct, and it's different from the role that we have with respect to the authorisation of medicines. While we receive and review applications from companies seeking to supply cannabis-based products in Ireland via the programme, the extent and nature of this is very different in terms of review. It involves initially reviewing the product applications against the criteria set out in the regulations. The key requirements for accepting a product onto the programme is that it must be approved for supply in another EU member state and is being supplied in that state. This is a way of providing access for Irish patients to cannabis-based products that are available to other EU patients that could previously only be obtained by travelling out of the state. It acknowledges the reviews performed by other member states and does not seek to create additional barriers where these reviews have already been conducted. Other requirements are that the THC labeling is sufficient in terms of detail to support safe and effective dosing and product use. It is also our rule to ensure that the products are aligned with the published clinical guidance. When our review is complete, we make a recommendation to the Minister where an application meets all of the above criteria. The final decision as to whether or not the product is included on the MCAP rests with the Minister. It is important to note, as per the criteria in the regulations, the overarching principle of the clinical guidance is that applications can only be made under MCAP where an equivalent authorised cannabis-based medicine is not available. Since the regulations came into force in June 2019, we have received 34 applications. Of these, 4 cannabis-based oils have been placed in Schedule 1 of the regulations, and 2 derived herb products have concluded the HPRA final review and are with the Minister for his final decision. 5 are currently under active review. In addition, 11 have been withdrawn or paused by the applicant company themselves. And in the case of the remaining 12 applications, the company has not met either the legislative criteria or the clinical guidelines, and these have been placed on the HPRA, on hold by the HPRA as a result. We are continuing to work with a cohort of these companies on these issues. The HPRA provides significant support to prospective applicants through guidance on both the legal framework and the product criteria to be met in advance of submission of an application. In all cases, we have direct meetings with these companies to advise and support their applications. The provision of this support also continues throughout the application review process. The first cannabis-based products are expected to be made available to Irish patients through the MCAP from mid-October 2021, which has already been outlined by other colleagues. Once these are accessed by Irish patients, the HPRA will receive any reports of suspected adverse events and review them for any signals of concern regarding the safety of the product. The HPRA will also have a role in investigating any quality issues that may arise and coordinate any action that might be subsequently required. Thank you, and very happy to take any questions.
Thanks very much, Loraine. So I'll open up to members. I believe our first TD for questions this morning is Bernard Durkan. straight from the Dáil chamber.
Thank you.
You're very welcome, Bernard.
It's a race. It's a race against time every morning. I want to first of all thank our witnesses for coming before the committee and for the detail given in their submissions. I think it's hugely important on an issue of this nature that adequate information is made available and that the integrity of the treatment is protected. And so my questions are simply the benefit risk assessment that has been carried out. It has been fairly thorough. Are you satisfied that it is sufficiently firewalled and that the products are sufficiently firewalled within the system so as to ensure that they don't fall into the wrong hands or that there is not access is not given to sources that shouldn't have that? In other words, strictly for medicinal purposes and by the authorised people. That's the first question. The next question is in relation to reimbursement. Are we satisfied that the reimbursement system is sufficiently responsive and active in its dealings with the patients? And the third question is in relation to the extent to which patients deemed to be in need. I know there were 34 applications, and I get the information in relation to the progress so far. But are you satisfied that the patients who are deemed to be in need and will benefit from access to the treatment, that they're getting access in sufficient time? In other words, easy, sufficient access without there being a danger of damaging the integrity of the whole process. 3 questions, Chairman.
Thanks very much, Bernard. Who wants to respond?
I'll ask Seán to come in on the reimbursement arrangements, and the other 2 questions seem to be the different sides of the benefit risk, whether we're allowing sufficient access where it's beneficial and whether we're managing the risk of it sort of leaking beyond the programme as intended. I'll bring in my own colleague on that, and maybe HPRA will want to say something. So Seán, if you could start on the reimbursement aspects.
Yep, okay, so on reimbursement, obviously clearly the MCAP has not started as of yet because there hasn't been a product. The MCAP is due to start in the next few weeks. We expect reimbursement will be reasonably seamless under the MCAP because we have an approved product and we have an application system that will be in place. So on the MCAP, I think that's probably going to be okay. I've no idea of the volume or the scale or the numbers, but we have sufficient staff to be able to deal with large volumes or small volumes, whichever it is, and we'll flex our staffing as need from other teams. So on that question, that's obviously the licenses are somewhat different in that they come in one by one, and they come from the department. And while that's not quite as seamless a process because it's an individual single approval for those products, but we are doing our best to be as responsive as we can on those, and the various arrangements have been put in place, including direct payment mechanisms. Sorry, have I lost the...
No, you're back on. You're okay. Walk away.
Okay, yeah. Grant, something's come up there. I wasn't sure if I was gone.
No, we're having IT difficulties again, so just bear with us. But we can hear you loud and clear, and we can see you now.
Yeah, no, I thought it was gone there. So that's that, and then obviously the other thing that has changed over the period of the introduction of the MCAP is that for one of the areas in particular, the epilepsy area. At the time that the MCAP was proposed, there wasn't a medicine approved or authorised in the market, and as Loraine earlier said, there is now a medicine approved or available, market authorised, and the HSE obviously has a process around new medicines and how those are assessed, and that process is ongoing as well. At the stage now of assessments, the health technology assessment is completed, and we're at the stage of that where commercial negotiations are ongoing with the the company. That's not part of the MCAP. Obviously, that's a licensed medicine. It would be separate to the medicine. But again, some of the patients will eventually, hopefully in due course, assuming that might be reimbursed, be covered with that. So I'm not sure if that answers the question, Deputy Durkan.
Thanks, Sean. I can come in on the risks of illegal access, Deputy. They're very much carefully managed and controlled within the programme. You would have heard Sean and Loraine speak about the specificity in who is a recipient of the cannabis-based products, the need to have a clear clinical need identified by a medical professional, and the doctor-patient relationship at the heart of the management of the treatment. Benefit risk analysis also feeds in very much into the HPRA's assessment of drugs, and did inform the restriction of availability to a number of conditions at an earlier point. And Loraine, would you mind speaking a little bit more to the benefit risk and the way that works?
Thank you, Deputy Durkan, for the question, and obviously a very pertinent one in the context of the role that we have. You're absolutely right. I mean, in the first instance, these MCAP products, they're not medicines in the conventional sense that you and I would know medicines. So, you know, the extent of data behind them, it's limited, and I've been very clear in relation to that. But in terms of being satisfied, yes, we are satisfied. What's here is in line with the recommendations we would have made in 2017. And you have to remember, this is a very limited form of access for those 3 specified conditions. But what's really important in this is a cascade in terms of the progression to treatment onto the MCAP. These patients have to have exhausted all of the available options. So when it actually comes down to that, you are really looking at where the options they have available to them, there's a clear unmet need. And in that context, I think there are different considerations regarding benefit and risk, and we are satisfied with the programme. And I guess there's a little bit of an overlap almost between the benefit and the risks at the individual patient level and the control of the system. In line with the clinical guidance that I have referred to, every patient that is put onto the MCAP programme, it has to be initiated by a consultant, and the enrolment process has been outlined. But per each patient, then there is a treatment programme that has to be put into their medical record, and that really sets out, you know, the background to the decision to introduce or to introduce them onto the programme, the product that they're going to be used, what the dosage is, and what's really important here as well is that there is an agreement on what the expected outcome should be in terms of improvement. So there's actual measurements put in place. And then there is a monitoring plan for the patient, and they are monitored at regular intervals to ensure that those improvements are actually being realised. There's also the overriding principle that anybody that starts on one of these products, you start low and go slow. So, you know, the dosage starts at the lowest level, and then, you know, it's worked upwards. But equally, if those measurements that I have spoken about are not met, there is also a work down as well, and that the treatment can be stopped. So it's very much an individualized program, completely kind of supervised at an appropriate level medically. And I guess in that context, that is part of the control system as well. Muiris, I don't want to overlap with what you've already said, but outside of this, because they are substances controlled under the misuse of drugs legislation, there is an additional tracking system under that there. So for example, of a wholesaler bringing in the stocks that have to be held in wholesaler for supply onwards to patients, there is a license system separately that tracks, and there is a reconciliation process done on the amounts that come in, the amounts that are used, the amounts that are in stock, and the HPRA has a role in monitoring in that as well. So there are many levels of control across the system to prevent leakage. And then I think from the benefit risk point of view, it very much so comes down to an individual patient decision, closely supervised by a doctor as well.
Thanks very much. I'm going to move on now to David Cullinane.
Thank you, Cathaoirleach, and welcome to all of our witnesses. We had a number of private briefings on this issue, and I just want to thank all of those who provided those briefings. This is a new area where we're moving, I think, hopefully in the right direction to enable products to be available under either license or prescription. So I know it is going to take some time for this new process to bed in. So, Ms. Nolan, I just want to start with yourself and your own opening statement, and specifically the part in relation to the MCAP state of play. So you say that 34 products applied under MCAP to be placed in Schedule 1, and of those 4, I think, have been approved. Is that correct?
4 have been included on the listing of the schedule by the Minister. 2 have completed our review and are waiting to go on to that. So I suppose in the round 6.
In around 6, okay. And 5 are currently under active review, is that right?
Yeah, we're still working through 5 others.
Working through, okay. So of those 6 that have been placed, well, 4, as we know, and maybe more that have been placed in Schedule 1, how many of those products will be available this year?
I have to say that, first of all, I should say that in terms of our role, we make the recommendation.
No, I
the Minister
understand
puts
that.
them
Maybe
on the
it's not
list.
you can answer it, maybe whoever can answer it. So
it's really important to kind of say that the company themselves kind of have a big part to play in terms of place it.
I'm just trying to figure out how many will be available, because what people will want to know is when will any of these products actually be available under the programme? I know there's a process, I know there's a role for the providers as well, but in terms of actual availability on prescription under this programme, we know that 6 will be listed in Schedule 1, and that's great, but how many of them this year will be available?
Deputy Cullinane, I think both Muiris and Shaun would have outlined that in their opening statements. The Canopil product will be available from mid-October, and Sean's hand is up there as well. And Sean, I understand the Kildare one is the other one.
Those questions to him, Ms. Nolan, thanks. So Sean, I'll just come to you. So of those products that have been placed in Schedule 1, and I know it was in your opening statement, so it's only 1 you anticipate will be available this year, is that correct?
Yep, there's four listed on Schedule 1 as we currently speak. We've engaged with all 4 companies. 2 of the companies agreed. 2 of the companies were interested enough to put forward pricing positions. 2 of them, one of the companies which had 2 products wasn't interested in putting forward a pricing position. And of the 2 companies for whom we've approved pricing, 1 has confirmed that they will launch this year, and we're awaiting confirmation from the second.
Okay, so we have 1 this year, and what about next year? Do we have any anticipation of how many we may have?
Until products are on the schedule, clearly the HSE won't be aware of what those products are and what they're approved. The minute products are on the schedule, we will engage with the suppliers of those schedules. There are 4 on the schedule. We've engaged with all those 4. Of those 4, all I can tell you is that 2 products, the supplier has said they are not interested in entering the Irish market, even though they went through the process. 1 of them has said they are. 2 of them have said they are. 1 of them has confirmed October, and the other one we're waiting for a date. And I won't know until we engage until other products are added to Schedule 1 and we engage with those companies.
Okay, and Mr. Flannagan, I suppose the reason why I'm asking is, and I accept that, and you may not be able to definitively say what might happen next year, but if we were asked as public representatives, we're holding a hearing here today to try and get as much information as possible for the public. So I think, is it fair to say the best I can say to people if I'm asked is that there is potentially 6 products that will have been placed on Schedule 1. Best case scenario this year, 1 of those will be available under the scheme to patients. Possibly maybe 1 next year, but we don't know. But I would say best case, I would imagine, given what you're saying, it will be 2 products next year, if that. Would that be a fair assessment?
I genuinely can't tell you about next year, but I think in terms of what can you be definitive about, that's what you can be definitive about. You can be definitive. There will be at least 1 product this year, and there will probably be 2.
And have you done any modelling then in terms of how many patients are likely to avail of any of these products, either the single product this year that may become available at some point, or next year? Is there any modelling done on what the usage is likely to be?
In the lead up to the introduction of the legislation, HICRA did some work from memory for the department. I think it's important to flag, since the legislation was published, there's been a significant change in the market, in that there is now a licensed medicine for the epilepsy indication called Epidiolex. That is going through the standard HSE medicines pricing and approval process, pricing and assessment process. And clear, so in other words, the medicine, a licensed medicine, which is very similar to the Canopil product, I think it's fair to say, is going through the pricing and reimbursement process, and we expect that may. I can't make any guarantees because obviously I can't make a decision until the process is complete. So that will probably, if that gets to the reimbursement list, that will obviously have an impact on the number of patients who might use the MCAP in the epilepsy indication in particular.
Yeah, I was going to get to that in a few minutes. So the Epidiolex one is important for epilepsy patients, and I know it has been licensed and is going through the reimbursement process. So hopefully that will be successful and it will make a difference. But I suppose I'm just trying to get a sense of how successful this program is going to be. So if it's only going to be one product this year, we don't know how many products will be available next year. You say that some modelling was done, but we don't really know how many of these products will actually be prescribed to patients. It's hard at this point to get a handle, is it not, on how successful this MCAP programme is actually going to be. I mean, I would have imagined that it would have been anticipated that more products would have been online by now, and more products would have been not just on the schedule, but actually available for prescription. So is it fair to say that it's a bit disappointing that at this point, for whatever reason, and it's obviously down to the companies themselves that have to engage, that as a start for this programme, as important as it is, only one will be available. We don't know how many next year, and we don't know how many patients will actually be prescribed this drug either this year or next year. Isn't really painting a good picture. Like, there's not a lot of information, it would seem, that I can give to the public or is going to be given to the public arising from this session.
Well, I think it's important to flag that if Epidiolex were to be reimbursed, we would expect of the order of at least 300 patients, possibly across those three indications, would be prescribed Epidiolex. Those patients would probably have been on the MCAP. And sorry, that information is from the health technology assessments on Epidiolex, which I have seen, and which I'm a member of the HSE Jurors group, so I'm required to review all that information. So roughly from memory, and again, I don't have them in front of me, the HCAs, but my memory was that there's about an estimate of about 300 patients per annum who might benefit from Epidiolex if it were reimbursed. In the absence of Epidiolex, all those patients would have been expected to come through the MCAP. So I think, I hear the criticism of the MCAP, but against that, I think that the world has somewhat changed in terms of, I think we're all agreed, and again, I'm not an expert on safety, quality, and efficacy. That's more Lorraine's role, but I think we're all agreed if there's a licensed medicine, the preference would be that the licensed medicine would be the mechanism used, provided that the HSE can agree pricing and reimbursement terms with the company. So I think that does change the picture from where we were when this MCAP was contemplated. I should also...
Do we have any indication, because I think that would be a game changer, and I accept that, do we have any indication when that medication will actually complete that process in terms of the reimbursement process? For clearance, I should say. So when are we looking for that to be a product that will be reimbursed?
Well, we're expecting that it will get to the HSE Jurors group in Q4 of this year. So in the next 3 months, which would suggest that a decision on reimbursement would be made late this year or early next year. And when I say a decision, obviously I can't indicate whether that would be a yes or a no, because I can't get ahead of decision-making process of the HSE, and particularly given I'm a member of the Jurors group.
My time is limited, so I'm just saying again, this is something that has to go in. I know there's a process, and I think we need to look at that process, to be honest, because the drug approval process for me needs to be overhauled. But it's going to go into the drugs group, which will obviously have to do its work. As you said, it'll be sometime next year, and we don't know when a decision will be made on that. So we're still some time away from any decision being made on that one, which brings us back to MCAP, which is one drug, one product this year. We don't know about next year, and we don't know how many patients will actually be able to benefit from the actual process. I just want to ask a question to Ms. Nolan in relation to an issue that keeps arising all of the time, and that's CBD products that have a trace of THC, and it goes back to a European court ruling on this matter as well, in terms of traces of less than 0.2%. And this comes from companies that sell these products that I'm sure lobby all TDs on a regular basis, where their shops are raided. They say that the products that they are selling have very minimal traces of THC, in line with that European court judgment. Can you just talk us through what the state of play is there? Because I'm looking at another one of the opening statements where it says it is currently unclear whether or not CBD-only products that contain only trace elements of THC can be processed for inclusion in MCAP as per existing legislation. So there seems to be some confusion in relation to this, and I suppose what we need is clarity. So when are we likely to see some clarity? Is that something the courts will have to decide, or is it something that the political system can decide?
Okay, again, thank you for the question. And if I can refer back to your last question, first of all, I would say the experience of Ireland in relation to a medicinal cannabis access program is not that different than any other European country. We would have followed closely the kind of progression of the system in Denmark. And to date, they have only 4 products that are included on their MCAP program. So we're certainly not out of kilter. At the end of the day, it's up to the companies to make the applications to us. It's up to the companies to meet the requirements that the legislation kind of has set out. The regulations removed all regulatory burden, really.
Sorry, Loraine, you've dropped again. So
sorry, I'm going to check out.
Yeah, we can hear you. You're back on again. Sorry.
Can you hear me now?
Apologies to people listening at home.
Okay, so the burden, it is a low regulatory burden system, and I don't use that term frivolously. So I do want you to understand that really at the end of the day, the company kind of controls whether something is placed on the market or not. And I would absolutely, totally stand over everything Shaun has said. The availability of a licensed medicine is the best treatment option that can be given to any patient. And I think the fact that we now have Epidiolex, which is a CBD-only product, has really changed that landscape. Your question in relation to the thresholds, yes, it is a very good one. I need to be clear. It is a policy area somewhere. I'm probably speaking on your area, but I'm happy to do it, and you can stop me if you want to intervene at any point. Under the misuse of drugs legislation, by definition, any product that contains THC, whether it's at trace level or not, is a controlled substance. That is the bottom line. The legislation is that clear cut. And the misuse of drugs legislation was put in place in the 1970s. That would have been kind of pre the evolution of a hemp industry, if you want to call it that way. So the situation kind of has moved on. So, I think we'd also have to look at, if THC is in there at those levels, is it having any pharmacological action? Probably not, because it is such trace levels. So the policy in this area, and it is complicated. It's not an easy thing to fix, because, it has knock-ons in the criminal justice system when the guards are, making street detentions. How can they tell the difference between cannabis that has no THC and cannabis that has THC? So it's not just a simple matter of changing the policy, because it has an awful lot of consequences along that. So I think that is something the department is certainly considering. But strictly speaking, they are THC containing products. There are no thresholds under our legislation, and that means they would be eligible for inclusion in MCAP.
Thanks very much. I'm moving on to John Lahart.
Thanks, Chair. Look, I've for a number of years had a very open mind on this, and approached the committee meeting this morning in the same vein. And I have to say, it is one of the most comprehensive presentations I've had the pleasure to listen to. I mean, almost all the questions that one would ask or could ask have been answered. The background to this, the international comparisons, the number of products, how the product is regulated, the dealing with the companies, the review that took place, and the consciousness that that review took place some time ago. So actually now you've embarked on a further parallel review, international best practice. And the reason I say all these things is it sounds from the previous speakers there's a little bit of disappointment. Often I think that there aren't more products on the shelves. Whereas you make it very clear that the approach to this is very scientifically grounded. I always fear that this debate, sometimes people like to polarize it, and that if you're not in favour of this, you're somehow conservative and a backwoods person and don't appreciate or realise the impact you're having on the quality of life of people. And that's notwithstanding the very passionate pleas that have been made down through the years in relation to the efficacy of some of the products. But that if you're on the other side of the argument, you're somehow progressive and enlightened and want to enable people to break free from the shackles of terribly tedious illness. So I think you've put certainly, and I'm in the middle. So you've answered a lot of questions I had, and I just want to there's a couple of short questions as I go through some of the contributions. Denmark 4 products, so we're kind of not taking our lead, but we're casting an eye to the Danish model. They've just 4 products. How long has Denmark been in a situation where is it consultants who prescribe in Denmark, and how long have they been in a position? Just a really short answer to these first few, please.
I'll possibly take that question in relation to Denmark. I actually couldn't clarify for you whether it is initiated by a consultant or not in Denmark, but there are other colleagues from the HPRA on the call, and if one of them, perhaps Aoife, might know that, Aoife, I'm very happy for you to come in there. The Danish scheme, they are due, it's 5 years old at this stage.
Okay, great.
And the Danes had committed to a review at the time they introduced it, so they should be at that time point as to kind of begin to embark on their review. So we kind of contacted colleagues that we would work with in this area in the Danish agency, and we are trying to find out more information on the status of where they are with regard to that review, because that will be very interesting.
So it would be important that you could let us know on the Health Committee, you know, if the fruits of that. Just in terms of, do we have an answer to whether consultants initiate the prescription or GPs there from anyone else?
Aoife, would you know that detail? And if not, we can follow.
Yeah, I don't know for definite. I know that we did base, you know, we did look to that model a lot, but I'll confirm that for you.
The THC references, so our regulations around that, which you're saying, you know, look, they are quite old, do they mirror generally, are they mirrored across the EU right now? Or do they run counter to most? So I see heads nodding, so I'll take that as a yes, that our treatment of THC is generally mirrored how other European Union countries deal with it. Okay. Yeah, the companies, in relation to the companies that are manufacturing this, without naming them obviously, is it your experience that those companies would be in the traditional pharma space? Would they be traditional pharma drugs manufacturers, or are they specifically in this case, in this space? I think that's for Sean, actually.
Sean, do you want me to take that one? It's possibly Deputy Lahart, more us, really. I'm sure Sean will have a view on it as well. Yeah. I'm going to ask him. I would say probably not. You know, they are not kind of what we would normally consider to be in the traditional pharma space. But I don't like the fact that this gets dragged into a big pharma and a small pharma argument.
Sure,
because
No,
we have to acknowledge the fact that there are many small companies that supply conventional medicines to our markets.
The next question then, and it's from Sean's, and I'm sorry, I know we always come across as rude. If you were here in person, you know, we're smiling away, but time, it's just the time piece. Sean, in your contribution, I just want to clarify that it's in the consultants, the information they're required to provide in relation to use of any cannabinoids or related medicines. Would that be standard in relation to an unusual, like would a consultant have to fill out these kind of forms and report to you on general prescriptions that they're providing to people, or we'll say unusual, maybe very rare drugs as opposed to cannabinoids?
In the main, prescription legislation doesn't, I imagine that the main difference, there is a very significant difference in that the legislation lays down that we're legally required to collect information in a register, so that in itself is different. And the legislation lays down the vast majority of, the legislation lays down the things that we have to collect. Some of the information that we collect, obviously the name and the address of the patient, that would be normal information that would be on every and any prescription that anybody would have. There is information such as the use that wouldn't normally be information that would be on a prescription, say for example. So we wouldn't normally see that even in our other reimbursement scheme.
Okay, thanks, Sean.
We would collect things like we would know the consultant, we would know their medical record number. All those type of things would be legal requirements as part of the prescription legislation for all medicines, but therapeutic use, I think, in particular, and the requirement to pre-approve is unusual. It's not unique, but it's unusual.
Okay. Loraine, you want to come in there?
Just on the point on the consultant, it's important, and I probably haven't clarified this earlier, it is consultant initiated as per the clinical guidelines. So once it's initiated, it can transfer then to a general practitioner.
Yes, that's very Oh, and it can transfer, once it's initiated, then it can transfer for repeat prescriptions, is that correct? Yeah, grand, okay. So the suppliers of two products, Canapil and the Tilray oral solution, they've submitted final pricing positions to the HSE. They've been accepted by the HSE in June, and one product, as you said, expected in October. In general terms, for Sean again, the HSE has designed an application form for prescribers to register a person to be treated. Would that be standard practice in relation to drugs?
No, but it's a requirement. It's a requirement for the register. We need to, before a prescription can be written, we need to provide the cannabis medical use registration number, and there is, so that's required in the legislation.
Okay. Again, look, I find very reassuring in the contribution from the Department of Health about the review, that you undertook a review commencing around the Minister's decision in 2016. You're now commencing a new clinical review that will continue the work. So this is constantly under review. When might we have, just a simple short answer, when might we have the results of that review? That's the Department of Health.
Yeah, thank you, Deputy. Work is beginning and is underway in sort of setting up that and refreshing it. Hard to put a time frame on it. There'll be an evidence synthesis, a review of international practice, and a review of the clinical trials of relevance in the intervening years to see if further indications can be added. I expect the review will take 6 to 8 months to complete, so okay. I would say middle of next year we would have that review refreshed.
Moving on to the HPRA contribution, I noticed when you say that the review concluded that from a policy perspective, should the Minister consider it in societal interest? Is that the normal use of language that you'd associate with this, as opposed to the medical interest of society? If it's not, if I'm picking on something, it just did stand out to me, or in the health interest. Should the Minister consider it in the health interest of society? But you said societal interest.
Yeah, and you're right, that was the term that we used at the time, but I can't say that it wasn't with the health interest behind that as well.
Okay.
It's the way the Minister would have considered it as well.
Okay, look,
it really came down to unmet clinical need, so that is a health interest.
I've very limited time left. You know the way we have, the normal process that medicines go through, and you did make the point that the virus has taught us an awful lot, the ordinary layperson, a lot about the process of approval. Are there any trials of these medicines that you know? Is that part of the process of approval?
Yep, clinical trial evaluation absolutely is necessary for a medicine to get approval. So maybe Gráinne, my other colleague, is online as well. To Gráinne, if there's anything you may kind of want to say there in relation to clinical trials, cannabis.
In terms of these particular products, or in general, I would say in terms of general clinical trial activity, there is some activity within Europe. It's pretty much at the same level that it was at in 2017 when we completed our initial review. And the areas of interest of those trials are chronic pain, psychiatric disorders, neurological conditions, including epilepsy, of course. And a lot of those trials are in fact relate to products such as Sativex and we know also Epidiolex in part. So that's in the general context, but in terms of the MCAP products themselves, the clinical, the review of clinical data is not part of the assessment.
Okay, thanks, Chair.
Thanks very much. I move on to our next questionnaires. Neasa Hourigan, please. Morning, Neasa.
Morning, Chair, and sorry that the bells are going in the background there. I hope that that's not too intrusive for people. Good morning, everyone, and thank you for being here. I just want to go back to the kind of the amount of products that are available at the moment. So 4 cannabis-based oils are already approved. Is it fair to say that each oil relates to a specific company? So for 4 oils, there's 4 companies? It's a particular product?
I'm going to get Aoife to answer that question for you, Aoife, because she actually it's her responsibility, that area, so she's best placed to give you the detail if that's okay. Aoife, can you hop in there?
No problem. So for the 4 products that are placed on the MCAP program at the moment, it is 4 oils, but it's across 3 different companies. So
okay, so there's 3 companies involved. That's okay. And of the 5,
Hourigan's apologies. Actually, that's actually, I put that in my. It's at the end of my opening statement, so the detail is there for you.
Okay, thank you. And the 5 under current review, are those oils or herbs? Or
the 2 that are with the Minister for final decision, so they've completed their review, are herb, and the 5 under review are oils.
All oils, okay. And of the 11 that have been withdrawn or paused by the applicant company, can we go through those? I presume it was the companies themselves that withdrew or paused?
So the reason they're paused is that there are some outstanding issues with them that I suppose would need to be resolved before they could progress. So they haven't been withdrawn or cancelled, but we are acknowledging that currently they don't. In the case of 6 of them, they don't meet the criteria set out in the regulations.
Like what? Sorry, could you give an example?
Sure. For the most part, pretty much all of these relates to being available on another EU member state. And the reason these are on hold as opposed to cancelled are that for these products, we're talking about the UK. And so we're hopeful, in conjunction with our colleagues in the Department of Health, that we will be able to make a legislative amendment to allow them to come into the programme. And so that's underway at the moment. So that's why they're on hold.
Okay, and so then, out of the 11, that's 6 and the other 5?
The other 5 are related to the clinical guidance. So either the THC was too high and not in line with clinical guidance, or else the product formulation itself wasn't in line with what was laid out in that clinical guidance for the 3 specified conditions.
In what way?
So it can be that the THC is too high,
got that
or
one.
It can be that the ratio between THC and CBD is not in line with what was set out.
And CBD, okay. Can I go through the aspect of the relationship of the healthcare professional? In one of your answers, I think it was yourself, Loraine, sorry, to another speaker, you said that one of the requirements is that the patient must have exhausted all available options. How does that align with the healthcare professional being able to make a medical decision for their patient?
Thanks, Deputy Hourigan. I want to bring in Dr. Lynch, who hasn't had a chance to contribute now. Thank you, Brian.
You're on mute, Mr. Lynch.
Can you hear me now?
You can, yeah.
So I think what you're asking me, Deputy, is that how does this translate into real clinical practice in terms of what is available on MCAP and what is potentially coming through? Is that your question for me?
My question is if the patient is being prescribed this medicine on the basis that the consultant believes it's the best treatment for it, in the normal way, there wouldn't be a requirement that you try every medicine before a consultant chooses a particular medicine for you. They'll look at the particular requirements and make a clinical decision based on their expertise, I would presume. So I'm just wondering about that requirement that they must have exhausted all of the other available options.
Yeah, I think that's an excellent question. First of all, if you look at the HSE document, I was on the HPRA committee that initially looked at these products, and then I was on the advisory committee which produced ultimately the recommendation for the MCAP. And if you look at the document, what we clearly stated there were the indications. And I'm an expert only in epilepsy, and I can only speak to epilepsy. And on that document, we clearly stated severe epilepsy where there's been a failure to respond to 5 or more standard anti-epileptic treatments. And then separately on that document, there are 2 specific, very severe epilepsy syndromes of childhood Dravet syndrome and Lennox-Gastaut syndrome. So I think those are 2 different criteria. I think it is perfectly reasonable, if you look at what is available to treat epilepsy, that one might try better evidence-based options first, in general for severe medically refractory epilepsy. And then if you look at those 2 specific childhood syndromes, one of which can be life-threatening, I would not apply those criteria. So that's what's in the document, and that's what we agreed as a committee relevant to epilepsy. So,
okay, and so can I ask a follow-up question then? There was also a statement that there will be a treatment programme required and a report. I'd like to know, it sounds like a report, the treatment programme where you have to outline the background. I'm not sure, is that different from what would normally happen with a prescribed medicine? I presume it's not. Usually you would give a background. But there's also a statement that there would be measurements required along the way, and I'm just wondering if we don't have the kind of agreed medical research, it's not considered it's not actually a medicine or recognised as medicine. Is it the consultative group who's deciding what the measurements should be and what the response should be in a given patient?
I think that stipulation came out of a recognition of a lack of available medical evidence for these products in a number of conditions, and in my area, epilepsy, that is still true. There was some medical evidence, but we need an awful lot more. So I think there was a recognition that if we were going to set up this program, that we should collect information. And I think you're absolutely right, that wouldn't be the norm. And that does require administrative backup, etc., and more paperwork, and that is an additional burden on the people who are providing the prescriptions and their staff and their environment. So it would not be the norm. I think you're right, but there was a specific reason why it was put in there, and that's still a valid reason, I think. But it does point that resources need to be put in place for people to collect that information and compile it and process it.
Thank you. Just to say, that requirement for measurement does seem somewhat it seems somewhat arbitrary. I would like to understand more about like how we're agreeing levels of measurement. And I know I'm over time, Chair, but I just have one quick question, and I'm not sure who can answer it for me. How many patients are we estimating will come through MCAP in the next 18 months, a year? Is that for you, Mr. Flannagan? I'm not sure.
I think it's hard, as I said earlier with Deputy Cullinane, it's very difficult to estimate because it will depend on whether Epidiolex is approved for reimbursement through the standard and ordinary process of the HSE in relation to medicines, because that would take potentially of the order of 300 to 400 patients away.
Okay, so let's assume that those patients are not in MCAP.
Sorry, what we'll do outside of the meeting is maybe we will pull out the HICWA budget impact, the HICWA numbers, the work that HICWA did on the when the MCAP has been set up, and we will send that separately to the committee as in relation to the numbers that were estimated at that time.
Okay, but you yourself must have some sense that if we take out those 300 people who might be serviced by a different programme, will the MCAP, is it 50 people, is it 100 people?
Well, I think the epilepsy indication is the largest of the indications. That was where we expected the volume of patients to be in. So if Epidiolex is approved, that's, so we were expecting of the order of 300, I think from memory it's 300 to 600 patients that might come through that if Epidiolex wasn't approved. But I will absolutely I will confirm that and come back on that with a note on that.
Okay, thank you.
I'm going to move on. Neasa, Deputy Gino Kenny is next.
Thanks, Gael, and thanks for all our statements today and all our witnesses. This has been a kind of very protracted last 5 years, to say the least, for those that are trying to get access to medicinal cannabis for their children or themselves, and it's been extremely frustrating, to say the least, and many people will be scratching their head and saying why it has taken so long for this process to begin. And the good news is that the process is beginning in a couple of weeks under prescription. My first question is in relation to the MCAP itself, and it's good that people will get a prescription as of the next couple of weeks, but how many clinicians have registered thus far to the MCAP, and have they registered patients under their care at the moment?
Clinicians don't register themselves for the MCAP. We get an application form from the clinicians. Given there hasn't been any product in the market that people could register under the MCAP, we haven't had registrations to date.
Okay.
So I would expect that would commence once the product is available.
Okay. So once the product comes available, as in mid-October, then the specialists under the three conditions, then they will prescribe their patients under their care the particular product, particularly Canna Apple. That's the way it will work, I presume.
Yes, yeah, and in advance of doing that, they will send us a registration number so we can. Sorry, they will send us a registration application so that we can place that person on the register and provide a CMUR number.
Right. And how long would that process take?
How long would it take in terms of when we get the form?
Yeah.
We would be turning that around within, we would try the same day or next day.
Okay.
Yeah.
So it could in the next 3 to 4 weeks, patients under that care of that specialist could be prescribed medical cannabis, particularly the Canny Apple, that product. They could have it, as under prescription in the next 3 to 4 weeks.
Yes, subject to the consultants deciding that was an appropriate product to use in the case of the individual patient. Yeah.
And is there any indications thus far that will there be kind of an uptake in relation to clinicians kind of having an interest in the program? Because a number of specialists came out in August saying that they were very concerned in relation to some of the products that are available under the program.
Again, it would be my expectation that with Epidiolex getting a market authorization, I think that for the epilepsy side, and actually maybe Professor Lynch might be a better place to answer this, but from my perspective, my understanding is if Epidiolex is reimbursed, that clinicians are most likely to move towards that, given it would be a licensed medicine, and they may feel that there would be clinical trials that would have been taking place around that. But I should stop and actually let Professor Lynch in there. I think would be more appropriate.
Thank you, Deputy. I think you've raised a very important point. And for us, as clinicians looking after patients with epilepsy, the evidence base is for pure CBD products. And there is no evidence base for products which contain a component of THC. Canopil, which is the product that has been mentioned a couple of times here, has a significant component of THC. And there is no scientific evidence base for use of such a product for epilepsy. Epidiolex, which is the pharmaceutical product which has been mentioned, is a pure CBD product. So from the very beginning, when myself and my colleagues have engaged with HSE and the Department of Health going back to 2016 on this, what we are looking for is a reliable, properly formulated, pure CBD, or as close to pure CBD as we can get, product that we can prescribe for our patients. And presently, that is not available through what is currently coming through the MCAP. And as has been stated by my Department of Health and HSE colleagues, if Epidiolex gets approved for reimbursement, that will solve that problem. And we sincerely hope that that will happen. But we would not, I can speak for my colleagues that we would not be prescribing Canopil because that has a significant THC component and there is no evidence base for such a product to be effective for children and adults with epilepsy.
Okay. Well, that's kind of, it's a strange statement because if it's going to be prescribable in the next couple of weeks, and you as a specialist saying like you would not prescribe it to your patients, then who's going to prescribe it?
Well, I agree. It's a strange situation. I have no control over what products have been applied for and approved through the MCAP. What I want very clearly is a pure CBD product, and the HSE guidelines document which came out of our committee review very clearly stated that that's what we wanted for epilepsy. But the MCAP as set up, and I'm not an expert on legislation and on the niceties of what can or cannot be submitted, it seems to be designed for products which contain a component of THC.
Okay.
And that is the problem that we have at present. None of my desire or making. I want to be able to prescribe a pure CBD product for my patients, and I want it as soon as possible.
Okay. Just in relation to the review, the scientific review, which was done in 2017, obviously things have moved on for evidence-based medicines around medical cannabis. Does the HPRA envisage that other conditions will be included in the programme? Because the programme itself is very, very restrictive, and you could have a situation where only a handful can get access. You could have a situation where more people could have access via the ministerial programme rather than the programme itself. So is there a basis to include other conditions? Because the omission of chronic pain, I think, was very controversial in 2017, and I think, my understanding, that the Danish Medical Cannabis Access Program includes neurological pain, because there's an unmet need for that particular kind of condition, around chronic pain. So, will the review look at including other conditions over the next 6 months?
I'll probably leave that to the people who are working on setting up the new review. I could speak to when the previous review looked at all conditions, including chronic pain and including cancer and palliative care situations, and looked at very carefully at the evidence in all of those areas. So I'm going to leave it back to the people from the HPRA maybe to answer about how the new. I'm sure the new review will be looking at that. Leave them to speak to them.
Thank you very much. Look, I'm happy to start here, and I might pull in my colleague Gornia as well on some of the questions there, if that is okay, Chair, and Gino, or Deputy Kenny, just to answer your question. What I will say in this is, yes, you are right. The Danish system does include chronic pain as one of the indications for which cannabis can be accessed. And I mean, when we looked at this back in 2016, 2017, at that time, we really felt that, although on one level it appeared there were, clinical trials that had been that had looked at the area of chronic pain, we couldn't, the evidence base just wasn't there to be able to stand over its inclusion as one of the indications. And there were many reasons for that. First of all, the quality of the clinical trials was quite poor. Many of them were not what we call randomized controlled clinical trials, which would really be considered, best design, removing of bias. So you couldn't draw conclusions for them. Pain had been studied across multiple different areas, using different cohorts of patients, using different formulations, and the evidence just wasn't there. Honestly, if I would say to you, from what we know about this, I would say the situation possibly hasn't moved on a huge amount since that period of time, and there has been quite a comprehensive review carried out by the International Association for the Study of Pain, and I will get Grania to come in on this point because she has all the expertise on it. So I would honestly say to you, I don't think the situation from our viewpoint would be different, but Muiris has indicated at the beginning that in the re-establishment of the clinical expert reference group from the department's perspective, that one of the first tasks that will be given would be a piece of evidence synthesis to consider how that may be carried out, because I think, a comprehensive review is warranted, and I would definitely acknowledge that. So, Gornie, maybe you might like to come in there in terms of the IASP review findings.
Sure, Loraine. And again, just to reiterate at a high level what Loraine has said, and as I said, the IASP review, which was I suppose as an organisation, it is a culmination of a multidisciplinary association representing healthcare professionals and scientists from many, many countries. And in March 2021, it published a meta-analysis and systematic review on the evidence around use of cannabinoids under the topic of pain. And, I would respectfully suggest to members that if you've got an hour to Google it, it's really nicely constructed and broken down into the safety, the efficacy, the pre-clinical data, the animal studies, and whether they do or can or cannot be translated into human or clinical impact, and also the societal and policy implications related to the use of these compounds for pain management. So it's an extensive piece of work by global leaders, and one of the work streams is in fact led by Professor David Féin of NUIG, who may be known to some of the committee members. In summary, the major findings are, the preclinical and clinical safety, and have identified, as Loraine has said, important research gaps. the lack of high quality clinical evidence for safety or efficacy mean that this particular association don't endorse general use. This association recognises the pressing need for studies to fill the research gap. And as I think I said at the recent private session, you know, none of us are questioning, I suppose, those for whom cannabinoids have provided relief and from the lived experience of pain. You know, in summary, it's about the quality of evidence here rather than the legitimacy of people's claims. So lots in there. Now, there was a recent publication in BMJ, you know, countering some of those claims, but there's definite differences in methodologies, and the methodologies used by AISP were very robust. So while, you know, as a HPRA, as an entity, we're a single entity, you know, we've done a quick review of the evidence in a very general way. So I wouldn't want to prejudge the outcome of a whole of health system expert review that might happen, as Muiris has outlined earlier.
Okay, thanks very much. Gino, just one quick question.
Very quick question, which is very important. In relation to those that have a ministerial licence, which are 67 individuals, at the moment, they will be outside the MCAP. And obviously for logistical reasons, because of the products they get from Holland, that cannot be included on the schedule. And I think that could be overcome. I think Denmark have a third-party licence company that actually does provide that particular product to the Danish Medical Cannabis Access Program. But in this situation where you have 67 individuals, them 60 individuals are obviously not monitored collectively. So in a situation, could they be included in the program as part of the kind of monitoring process? Because the vast majority of them would be for refractory epilepsy, but could they be kind of a part of the program but not being prescribed the medical cannabis products under the schedule, but can they be monitored as part of the program?
Thank you, Deputy Kenny. I think I'll bring in Anne-Marie here just talk about the review of MCAP. Will take account of those wider circumstances of those patients and the ministerial licence, and explore how the extent to which they could be facilitated through a reworking of the MCAP. Anne-Marie, can you come in?
Sorry, can I just clarify, do you mean the monitoring of these patients be done through the mechanisms in the MCAP, or that these patients be supplied their products through the MCAP scheme?
Monitored.
Monitored, yeah. Well, I mean, the every licence that's granted lays out the requirements for the clinician to monitor the patient, and that's not information that the department then collates. It's a doctor-patient relationship. Any adverse reactions to the products will be reported to the HPRA, and the HPRA does gather all of that data. But in terms of the clinical benefits seen from taking this product, that's not information that's currently gathered by us. But that could be looked at in the MCAP scheme, you know, a way of gathering the information as to the effectiveness of these products. It's not something that's currently being considered, bringing those patients in. As has been said multiple times already, we would envisage if Epidiolex becomes available for reimbursement, a lot of the patients will also leave the ministerial licence scheme. So overall, there's the three indications that the vast majority of patients are for the refractory epilepsy. If Epidiolex is available, they will be gone. And our understanding is that since the MCAP was first set up, the clinical needs of patients with MS and with the severe nausea are largely met by other licensed non-cannabis based medicines. So we don't see a huge demand for patients with those clinical needs coming through either the MCAP or the ministerial licence programme. Okay.
Thanks very much. And again, maybe it's something that as a committee we could follow up on in relation to your suggestion there about the monitoring.
Yeah, that's something that we can look into and come back to you.
Great. Thanks very much.
Okay, no problem.
Colm Burke is next. Colm.
Yeah, thank you very much, and thank you to all of the guests who have done the presentation here this morning and for dealing with the questions. Just in relation to Tilray oral solution, this may have been answered already. Have there been any indication given when this will be available, and are we likely? Can it be followed up to see that there's a definitive timeline provided as to when it would be available now that it is, that it should be available on the market. That's number one. Number two, I just want to check about the people who are prepared to prescribe. Are we, and I'm talking about in particular in relation to indemnity cover, are we confined to consultants only employed in the HSE, or can consultants who are working privately and not in the HSE prescribe? And number three, the question I want to ask is the geographical location of those who are already involved in prescribing. Is it just totally Dublin, or are there people outside of Dublin who are prepared to prescribe? And finally, can I just ask a question? I'm just looking for clarification. In the Mr. O'Connor outlined that there was 192 licenses have been issued in respect of 67 patients. I'm just wondering, why did we need 192 licenses for 67 patients? Maybe I might get some clarification on that. Thanks.
Will I take the Tilray, Muiris?
Please, Sean, yeah, and I might bring Connor in then on the detailed questions then about the consultants outside the HSE, the geographic location, and the mismatch of licenses and beneficiaries. Thanks.
Yep. So, Deputy Burke, on the Tilray, we do engage with companies on an ongoing basis, but we don't at this point have a date from the company as to when they will be in a position to supply. And I'd be reluctant to make any commitment because at the time we were in private session before the committee, we expected a company would be in position to supply in July and August, and we don't have a supply yet until October. You know what I mean? So I'm comfortable about the supplier in October, but I'm not comfortable in relation to making an estimate as to when Tilray definitively will be in position. But we do keep that under. We do keep in contact with the company, and we will chase again. And in terms of, do you want me to? So yeah, that's the question I can answer. Yeah, sorry.
Thanks, Sean. Connor, can you come in on the consultants outside of the HSE and then the geographical spread of prescribers under the ministerial license or under the MCAP? Thanks.
Thanks, excuse me. As regards the licenses, Deputy, the information said 192 licenses have been issued for 67 people, which is correct. However, the first license issued at the very end of 2016, so that 192 is since 2016, to a total of 67 individuals. Currently, I must say a license, the first license is for a period of 3 months, and second and subsequent licenses are for 6 months. So a license isn't infinite, and it needs clinicians will need to apply after their first license every 6 months to renew the license. As for the 67 individuals, currently now there are approximately 40 patients who are actively being treated under the license program. So that's where that stands at the moment. The geographical spread under the license scheme, we have patients from all around the country, east, west, north, south. So it really is at a national level. As regards to clinicians at the HSE, I have to say I'd have to come back to you on that, Deputy. I'm not certain on that. We can back in writing.
Yeah, my understanding is that there is a difficulty on indemnity cover. And I think when this started off back in 2017, I was on the health committee at the time and this issue came up. And I think my understanding was the HSE agreed that whatever cover was there would be provided to the clinicians who were prescribing. But I'm not sure if that indemnity cover is available to people who are not employees of the HSE. So I think it might be interesting, it might be worth looking at. When I'm talking about geographical cover, I'm talking about medical people who are prescribing. It's that geographical issue that I'm more concerned about. Are the people prescribing only based in Dublin? Are there consultants outside of Dublin who are prepared to prescribe?
There are consultants outside of Dublin who prescribe.
But in each, like say Galway, Limerick, Cork, or is it just?
I'd have to go back and look at my tables for specific details, but we do have prescribers.
The follow-on question I want to ask, and that's about people who have, in particular in relation to pain, and I've come across a number of people, for instance, who I know are accessing cannabis products, not necessarily through the system. Has any study been done with GPs where they're aware of this happening, and as regards to getting a true picture of this particular challenge that we currently have? I'm just wondering, is Mr. O'Connor maybe?
Yeah, I don't think that's on our radar, just given the nature of what you describe, Deputy Burke. And I think as part of the review, we could ask for that issue to be explored, the extent of use beyond the programmes.
Yeah, because I think one of the problems that we have is that people are going down that road because they find the system currently that's in place is too complicated. And I think we need to get a truer picture of the challenges that are there and the challenges that, that medical practitioners face as well, where they know this is happening, but are, they don't want to intervene. And I'm just wondering if some serious study can be done on that whole area.
That's something we can look into, Deputy, and thanks for the advice in relation to it. I think it does warrant a bit of investigation, and it is something at this point when we're framing the terms for a refreshed evidence base. I mean, I expect it to be difficult to gather solid evidence on it, but maybe we could work through the GPs and so forth to determine the information that's available in relation to that.
But I'm sure if you engage with one of the universities or even all of the universities working with GPs on a confidential basis, you could get a more accurate picture of what we're really talking about here, because I do not believe that we have an accurate picture of the challenges that we have and how do we then, I know we're looking at other jurisdictions and I think that's important as well. But maybe we might learn from a very comprehensive study in this area so that we can plan for the future on it.
Thank you, Deputy.
Okay. I think that's, sorry, I think, Chair, that's my question.
Thanks very much, Colm. I just have a couple of
members as well for the response.
Thanks again, Colm. I just have a couple of points or maybe questions as well, but just from listening this morning, and I know Deputy Kenny wants to come in later as well, but I've listened to some of the submissions this morning, and it seems a very tortuous route to try and get access to a product. And I note that you were saying that that in recent years, both Ireland and abroad, the using of cannabis products for medical reason has been an issue of social and political debate, and calls for cannabis products to be made available to Irish patients. And my understanding is that for anyone to go down the route of trying to get this product, it's a fairly tortuous route, but it's also, I suppose, those families or those patients believe that these drugs work for them, that they're transformative. In many cases, they've tried everything else, and this is sort of a last hope. And it just seems that the route that people have to go to, and I can understand maybe people travelling abroad to try and get access and so on, particularly if you have if a child is involved and you can't get access to these products in Ireland at the moment. I'm just wondering, I suppose the question that people have asked, and I think it's been asked this morning, but again, people at home will be asking, does it have to be this complicated, the process? Because I suppose people who are looking in, now we haven't as a health committee had the drug task forces in, but we know that the availability of cannabis per se, and cannabis oils and various different elements of cannabis is widespread within the community. We know that the THC level has been, it's 20 times higher than it was only a couple of years ago. And again, that's the information coming from people that are experts in this. So, when we're talking about this tiny amount of THC, it just reminds me of years ago when I was a kid. There was a product called ginger beer, and there was supposedly alcohol in it, and I suppose some kids would try, we'll have to drink all these ginger beers, but to get a high out of it, you'd be drinking ginger beer forever. And I'm just wondering, these products there, and I understand that it's under the Misuse of Drugs Act, but it seems a tiny amount that's involved. And for the people listening at home, the THC is supposed to be the element within cannabis that gets you this high. So we're talking about not, tiny percentage. So do we have an idea of, how much of this cannabis oil would you have to take to, for instance, supposedly to get a high, under the present laws? If that's the worry that we have, that people are going to be willy-nilly going to this to try and, as a backdoor to try and get use of cannabis in Ireland. So is it the tiny amount, the THC that's in it? Do we need to look at that as as legislators in relation to that? I suppose that's one of as a committee we would appreciate if you could come back with us our answer today. Do we need to look at this area? As you as clinicians and people who are experts in this area, I haven't. I don't really have a clue. But I do know that the amount of families that have, approached us about this, that it was really their, it was, as I say, their last hope. So, is there anything specifically, for those families that are in that situation that we should be doing as legislators in relation to these, the availability of these products? Is there anything we can do as legislators in relation to the slowness of trying to get these products through the system? And I accept what you're saying, that if pharmacy companies are not putting them within the system, well, it's we're not going to get difficulty. But if there's a huge amount of potentially products there, and again, is there anything resources-wise or legislation-wise that we can, that the minister or we can be doing in relation to that? And I suppose the last question I have is in relation. You mentioned about the contact with the Minister for Health with his counterpart in Denmark in relation to this issue. But is there a need for, because of the Charters route and the difficulty that people have of trying to get products and clearance and get those products into Ireland, is it necessary for the justice element, or the Department of Justice or the Minister of Justice to similarly talk to their counterpart? And would it be useful, again, as this committee, to talk to our counterparts in the Netherlands, again, to try and smooth out some of those difficulties that are facing those families that are clearly in need and find it extremely difficult. So they're comments, but there's a couple of questions in there, and I just wonder would someone reply to those?
Thanks, Deputy. I can start, and I'll bring in Brian for clinical view, and Loraine as well. You describe it as torturous, and I acknowledge it is. There is a lot of process in the schemes, but we really do need to take a risk-based approach, and the benefits of taking THC in particular, I think, need to be higher than the risks, and it's really only a clinician, I think, that can make that call. So I'll bring in Dr. Lynn, if that's okay at this point. Thanks.
Thank you, Deputy. And I think you've echoed the concerns of patients and their families, and I hear those concerns regularly, and I share a lot of the concerns. Firstly, there are lots of people accessing unlicensed versions of CBD in the community. The problem we have with those products is that we just don't know what's in them. We know what is stated on the tin, but we don't know what's really on the tin, and that's why we're looking for properly manufactured and verified and sourced products. I think your point about the low content of THC is a very good one as well. The product that I'm accessing via ministerial license for a couple of my patients, for total, I've had around 8 applications, I think, for ministerial license. That has a very low content of THC, and that's why I'm happy using it, because I think it's a minuscule amount of THC. So I think that is an excellent point. And unfortunately, that still comes under the heading of a substance that's under the substance abuse guidelines. The Epidiolex product, which is a pharmaceutical product, would be essentially a pure CBD product and doesn't. And I think that's a very valid point. Unfortunately, Canopil, which is the only product that we see coming through the MCAP right now, is a high THC product. It's certainly not an insignificant content of THC. So it's just not something that has any evidence base for prescribing for epilepsy. So I think there are a number of extremely valid points that you make there. And I've met many families, and I have many children under my care where families have gone and accessed non-proprietary CBD-based products in various sources themselves. And I share your frustration, and I can echo the frustration of all my neurology colleagues, adult and paediatric, that we began this process in 2016, and it is a very slow process. Thank you.
Okay. Anyone else?
If I may, Chair, it's Loraine, if I could come in there.
Yeah.
Look, I think you have raised some very valid points about, and I take your point about the very small content of THC that's here. I suppose as a head of a medicines regulatory agency, I'm not necessarily looking at this from the point of view of the psychoactive substance content. I mean, I think we all acknowledge that what patients deserve most is evidence-supported treatments. And really for me, fundamentally, this is not necessarily about this being a THC-containing product or not. There are many controlled drugs under the misuse of drugs legislation that are regular conventional medicines. And I'm talking here about all of the opiate products, I'm talking about the fentanyl, and they have all reached the standard and the evidential standard that is required to achieve a medicine's authorization. So fundamentally, we have to preserve those standards. If cannabis wants to be a medicine, it has to reach the same evidential standards of all medicines. It has to prove it works, it has to prove it's safe. So fundamentally, that's what this comes back to for us as well. It really is around a lack of an evidence base. And unfortunately, being a controlled substance is one element of it, but the evidence base is not strong enough for this to be a more routine process in terms of access that we all know for other medicines. And unfortunately, until that advances further, that is the circumstances, this will never be a freely accessible program. I certainly accept the point that we have started something with the MCAP that needs to get underway. We need to be informed that experience, and we can look at how we can move that along and support that, and a lot of what Muiris has sort of said there. But we do need to be careful in this debate that we preserve the standards that we all expect for the medicines that we take, that we can rely on them to be safe and that we can rely on them to work.
Okay, and just on the Dutch authorities and, that the difficulty that's there, is there anything we can do as a committee or, as legislators in relation to that? And does there need to be a conversation with, justice in Ireland and justice in the Netherlands? Or can anyone really answer that for me?
I'll bring in Connor there, Chair.
Yep. Connor.
Thank you, Chair. Ministerial representations were made to the Dutch earlier on this year in order to facilitate the commercial import of these products. But the Dutch restrictions and the commercial export of pharmaceutical sales of cannabis-based oils outside the France. So we wrote to them in those terms and asked them could they facilitate us, and they came back and said they wouldn't. And as our opening statement said, they would facilitate individual prescriptions for patients, for which since April of last year we've been collecting.
Sorry, Professor, we can't hear you. Would it be possible to?
Sorry.
Yeah, We're having difficulty hearing you this end. You were saying?
Can you hear me now?
No, it's still very low.
Is it?
Do you want to ask him to take his headphones out?
Does anyone else having difficulty hearing?
What?
Take his headphones off and see if it makes a difference.
If taking the headphones off make a difference?
Does that make a difference?
Yes, it does. Yeah, thanks.
Okay. Sorry, will I start again? Or?
Please, it's just some of the members that couldn't hear you there.
Okay.
Thanks.
No, the ministerial representations were made to the Dutch to ask them could they facilitate us in importing the medical products into Ireland for the MCAP, or to be considered for use in the MCAP. And the Dutch, they wouldn't change their stance, which is they won't allow the commercial export of those products. They will allow the filling of individual prescriptions, which is what the patients in the licence programme are doing. And since April of last year, Ireland has been operating a system where we are bringing the products in for the patients and delivering them to their homes, and that programme will continue. The Minister announced last December that would be a permanent fixture. That has made the measure a lot easier for the patients.
Okay, thanks very much. I've a couple of more members that have arrived. They were at other meetings, so Senator Martin Conway.
Chairperson, and I actually was following proceedings in my office, so I was, in the first instance, just like to thank our guests for their comprehensive presentations. A couple of quick questions. First question, in your opening statements, you referred to scientific information and relying on scientific advice and so on. You might just maybe give us a little bit more information on the sources that that scientific advice is based on. I'd just be interested in that. Secondly, you said that there were 6 suppliers identified. 2 of those suppliers decided that they didn't want, although they engaged in the process, I think you said to Deputy Cullinane, that they decided they didn't want to supply to Ireland. Is there any particular reason why they engaged in the process, but then opted not to bring it to its finality and supply to Ireland?
Thank you, Deputy. On the scientific advice, I don't know, Loraine, do you want to speak to that from the perspective of the earlier review and our intent to refresh that?
I may be answering this in the wrong context, so Deputy Conway, stop me if I may be going off the point to answer your question. What we were really talking about in terms of the opening statement was that it was the lack of evidence to support a demonstration whether these products had an effectiveness and efficacy, meaning they would work or they were safe. And that was, that evidence for us is generated through a very long development program for any medicine, and it can take a number of years for that to happen. And I think it's been very well illustrated even by the pandemic and much of the information that was in the public domain in relation to what contributes to the authorization of vaccines. We all would have heard about the coverage of the pivotal clinical trials. And you can really see through that process, there is a comprehensive building of evidence which demonstrates the safety and the efficacy that is done through clinical trials, but also in terms of characterization of the manufacturing processes so you can stand over the quality of these products. So from the context of what's in the MCAP, the evidential base for those is not there. The contrast to that would be the other 2 authorized cannabis medicines, which are Epidiolex and Sativex. They would come onto the marketplace with that evidence well behind them and a confidence in the fact that a benefit risk evaluation has been carried out both by the company, that has been independently reviewed by regulatory experts, and they have received a marketing authorization. So that in totality is the kind of scientific basis or scientific evidence that we were talking to. So I hope that does answer your question.
No, it absolutely does. And just in terms of the other question then, as to why a couple of suppliers decided to withdraw from the process.
Okay, and Aoife, my colleague, has already kind of outlined these, but I'm happy to refresh over what she has said, and I don't have the numbers, so I may have to go back to Aoife for those.
That might be mine, Loraine, actually. Yeah. I think if I understand it correctly, Deputy Conway, you're asking of the 4 products that were put on the schedule, why did 2 not progress? So I think that's beyond.
Sorry, Sean.
Yeah, that's exactly. Is there lessons that we all need to learn from that process?
Yeah, the 2 products that didn't progress are from one supplier, and that supplier made a commercial decision that it was no longer interested in the Irish market, as I understand it.
And was that now because they didn't have the volume? Because, you know, I think, did you say it's 63 individuals throughout the country is the number that's actually benefiting from this programme? Is it that the volume wasn't there for them to make it commercially viable, or was there some other reason why they made that commercial decision?
I think on the numbers we need to separate the ministerial licence programme, which the department colleagues have explained. That's where the number of 67 comes from. Yeah. The MCAP will be a different programme, and there will be different products. Most likely there will be the products on the schedule. So I presume when they did, from an individual company perspective, when they did the economics on it, it just wasn't commercially viable in a small market for them, or they decided it wasn't a priority. And on occasion, maybe companies kind of say one of the reasons why, as I understand it, and I'm open to correction on this, that there can be delays in supply is companies have pipelines, of manufacturing pipelines, and they have to get sufficient quantities available to supply different markets. And it could be something as simple as that. Maybe they just weren't in a position to prioritize sufficient stock.
Finally then, and maybe this is kind of...
And I should say, Deputy Conway, we wouldn't be party. Obviously, we're not in the boardrooms of those companies, so we wouldn't be party.
Yeah. Okay, but just another question that strikes me: is there any Irish company looking at developing these products?
Would you like me to come in there?
Would you be able to come in there if you would?
Sure. So the two products that are with the Minister for final decision at the moment are being brought in and have been put through the application process by an Irish company. The product itself is not manufactured in Ireland, but the applicant is an Irish-based company.
Okay. Well, wouldn't it be nice if some of it was actually manufactured in Ireland as well, but that's for another day. Listen, thanks very much. Appreciate your contribution.
Cathal, Crowe is next.
Thank you, Chairman. I had clashing meetings, but I have been able to follow a good share of the deliberations today, so apologies. There's a number of points I just want to make, and I just thank all of our guests. There's quite a number of them here today, and it's good to see them participate in this meeting. If I could first turn to the Health Products Regulatory Authority, and specifically Loraine Nolan. So I've noticed over the past 18 months or so, there's a large array of CBD oils on sale in shops, and I know that I believe your authority have oversight over these, and I was just wondering, could you talk me through, because I did buy over the summer some of these for an elderly relative who wanted to try these to alleviate pain that they were experiencing on an ongoing basis, but the advice I got in the shop, I think, was a little bit substandard to what I'd have wanted. And I was just wondering what kind of regulatory oversight do you still have on these products as they enter the Irish system? Thank you.
Sorry, it was on mute there. Very happy to take that question, and it is a very good question. I mean, CBD itself is what we would consider a borderline product. It's contained in cosmetics, it's contained in foods, food supplements, and also contained in medicines. So what you're talking about there are in those shops are what are classified as foods. So they should not be making any medicinal claims, and certainly anybody working in those shops, because they're not qualified healthcare professionals, shouldn't be giving any advice in relation to whether or not these products can control pain, because they're not meant to actually do that at all. So CBD is listed by the European Commission as what's called a novel food. Those products have a different concentration of the CBD in them. Epidiolex is a 10% weight by volume products. Those products can have up to more or less a maximum of 3% and below that are in them. So it is part of our market surveillance program, and it is an area in which we are very active. So I'm going to pass to Aoife, because it is Aoife's team and in our agency that will look over that program. And we have taken action on those products where we have found them in shops and we have found them to have made claims. So Aoife, I'll pass to you on that.
Sure, thanks. Yes, as part of our market surveillance program around retail sales, we look at a lot of CBD products. There's a lot out there, as you mentioned, and specifically from the HPRA point of view, what we're looking at is to make sure that they don't make any medicinal claims. And where we find that they do, either on the packaging, labelling, or else on maybe the company website, we will take market action where required. But for the most part, we engage with the suppliers and the retailers with a view to removing those medicinal claims and bring it back in line with, I suppose, the FSAI position on the requirements that they need to meet as food supplements alone.
Okay, thank you. Just as a follow-up to that, maybe I differ with you on this, but I do think there's certainly, for someone who's experienced a lot of pain and anguish day to day with their health concerns, I do think it's something else worth trying. I do hold that view, and it was for that reason that I went in and bought this. So that's the positive of it. But then I felt that when I was in store, that the retail assistant was giving advice over and above maybe what should have been given. I also felt that, you know, we've all been there on a Friday night running up to your local Tesco store buying a bottle of Calpol or two, and then you're told by the retailer that's the most you can buy. But it seems to me that you can buy the whole shelf of CBD oils. There doesn't seem any cut off from what I could see on the day. Maybe there is, maybe you could enlighten me on that. And you might also just go through head shops. These were very much in vogue a decade ago, and there was a whole national debate about that. And there was an analysis of a number of products being sold in them. But I note that Dr. Pierce Kavanagh of the Department of Pharmacology in Trinity recently was highlighting the presence of, I hope I pronounce this right, Nafirone, which is again being sold in head shops, and maybe they're calling themselves something different nowadays, but certainly it can be purchased in shops in Dublin City today and throughout Ireland. And I was just wondering, have you regulatory oversight or concern relating to that, Ms. Nolan?
Maybe come first of all in relation to the paracetamol products. The paracetamol controls exist for an entirely different purpose. Paracetamol is a drug that's very commonly used in suicide. So the retail sale restriction that you would have experienced there in relation to purchasing of paracetamol is actually designed as a measure to kind of prevent or mitigate against that. So that is the reason for that. I'll still come back to the point that those CBD products are foods, and that was what they are being sold for. And I can understand the limitations of the shop assistant's advice in relation to that, and that is why, you know, we would always advise anybody who's suffering from pain. And I can understand, you know, a request for an alternative, but the best source of guidance on that is from a qualified healthcare professional in relation to controlling the pain. In relation to the head shops area, you know, it depends on the nature of the substance, and I'm going to speak about this in a little bit more generality. If the substance is included under the Misuse of Drugs Act, that is sold in a head shop, or is a derivative relating to that, the enforcement action actually comes from the Gardaí in that context. I guess then it always comes into a question of whether or not the substance in question can be considered, you know, medicinal or something that will be used in a medicine and is considered to be pharmacologically active, and it is an unauthorised medicine that is being sold. And it is then down to the question of whether or not, because some medicines can be sold in general retail outlets, that's where you will see, you know, common analgesics and sold in, you know, retailers, as you mentioned, Calpol there. So, you know, head shops can sell medicines that would fall into that characterisation, but anything that would warrant prescription control, clearly they shouldn't be sold in head shops. And that is the focus of our enforcement work.
In my last few seconds, I just wish to finish with a few comments myself. It's a position I've had in my mind for a number of years. I think we need to have a national debate, Chairman, on cannabis overall. It's a fact that in Ireland, in many homes, in many social outlets, people consume cannabis. And as a society, we've chosen to ignore this for a long time. I lived in Belgium and Holland for some time, where it's regulated by state, Department of Agriculture, Department of Health, and policing. I don't think we should move immediately to a model like that. I'm not suggesting that for a moment, but there needs to be a national debate where we perhaps look at the level of criminality that deals in these drugs and say, is there a way that state can intervene, remove that layer of criminality, and look at a problem that is out there and look at regulating it, maybe taxing it, quality controlling it like they do in some countries vis-a-vis Department of Agriculture. But I think at the very minimum, debate needs to happen on it. I haven't firm views either way, but that debate should happen. We shouldn't be shying away from it. Thanks, Chairman.
Thanks very much for that. Can I invite in Fáil and Wynne? Fáil, you're very welcome. I think it's your first time to address the Health Committee.
It is Gurmagat Cahirloch, and many thanks to all of the members and for the information that you guys have provided thus far. I have 3 questions that I wanted to ask today. So my first one would be just around the numbers of, I suppose, patients or individuals nationally that are availing of the MCAP treatment. And then my second questions are that I am aware there's 3 qualifying conditions at the moment. And I'm just wondering, is there, I suppose, an opportunity there to widen the conditions that qualify a patient for inclusion on the MCAP programme? And then my third question is that I am aware of a constituent, for example, in Clare, that has a rare condition who has a consultant, but has not been afforded the opportunity to be included on the MCAP programme. Instead, they have spent several years now going through various types of medical treatment that had adverse side effects on that individual, and didn't, resolve the issue or have any kind of positive impact on the condition. And strangely enough, I suppose the consultant, hasn't offered the opportunity to be included on the MCAP programme, for example. Instead, they want to start the whole medical process or treatment all over again, whereby the individual will be prescribed every medication that they have already tried for the last number of years. And I'm just wondering if you would be aware of such cases happening and occurring, and what would be your thoughts on as to why these situations would be arising, because I am conscious of the fact that the patient is Clare-based, and I'm just, I suppose, wondering about any kind of urban-rural divide when it comes to maybe this kind of treatment. Gurmagat.
2 questions have been answered during the meeting. So if we maybe just concentrate on the last one, and I think that was touched on as well, but maybe if someone wants to respond on the last question. I'm just conscious that we're running out of time. We are the Health Committee, and we're working to guidelines that are laid down by the House. So would someone come back on that last question? The difficulty with patients.
Yeah, I'd just say, I'll bring in Anne-Marie, it's a clinical decision of the doctor or patient before requesting a patient gets cannabis on a licence. So people really do need to engage, as is the general advice in relation to health, with their medical professional and discuss the issues of the relevance of the cannabis programme in that context. I don't know, is there more? Loraine, maybe, or Anne-Marie, you want to add?
Where to let Anne-Marie maybe add to that in terms of the urban, rural, that kind of area, I think is probably the last piece. There was just one point in relation to the situation in Denmark and consultant initiation I'd like to come back to. I have the information now for the committee. So I'll let Anne-Marie go first.
Okay, yeah, just to reiterate what Muiris said, it's a clinical decision and the clinical relationship between the doctor and the patient, and it's not appropriate for the Minister for Health or people in the department to comment on that relationship, and that's the trust that's given in that relationship in terms of what is prescribed. So that the licence programme is there, it's available to any patient once the clinical decision has been made. In terms of the rural urban divide, we're not seeing a divide, that it's only Dublin-based consultants using this scheme. So I don't think location is an issue in terms of access for the programme. We are delivering cannabis-based products to patients all around the country. So we're not seeing it from our side that anyone in rural is disadvantaged.
Okay, can Loraine, do you just want to come in at the end on that consultancy thing?
Thank you, Chair. Just a very quick update. The question came up earlier as to what the situation in Denmark was, and was a consultant required to initiate the treatment under their Cannabis Access Program. It can be, any doctor can be prescribed, but for particular conditions such as a neurological condition, such as epilepsy, multiple sclerosis, or spinal cord injury, it has to be a consultant that's involved in the prescribing.
Okay, thanks very much. I want to thank Muiris for helping us guide us through the meeting here this morning. Farming out the questions to yourselves. I think it was really useful, certainly for the committee, but I hope it's also useful for people that are listening at home and that are trying to go through the process of it or looking for information in relation to it. I think it's, this morning's meeting has thrown up a number of questions for us as legislators, but also as a committee in relation to health, and I think it's something that we might come back with some sort of recommendations. I think it was really helpful this morning, and appreciate you spending time and coming in and the information you're giving us. So that concludes our meetings for today. I want to thank you all most sincerely for your helpful contributions, and our meeting is now adjourned until Wednesday, the 6th of October at 9:30 a.m. Thanks very much, everyone, for contributing this morning.
Thank you, Chair. Good morning, everybody.
So.